Hello, and welcome to this educational series provided by Integrated Health Partners to educate and support providers and coders in the transition over to the risk adjustment methodology. My name is Nancy Mundock, and I'm the Director of Coding for IHP and will guide you through this presentation today. During this presentation, we will review hierarchical condition categories, or HCCs, Category 21, Protein Calorie Malnutrition, and HCC Category 22, Morbid Obesity. Morbid obesity can play a factor in many other chronic conditions such as osteoarthritis, PVD, neuropathy, diabetes, and heart disease. It is important to document all chronic conditions for a patient on a face-to-face encounter in order to receive proper reimbursement for treatment of the patient. According to the CDC, more than 93.3 million American adults are obese, meaning they have too much body fat. Obesity occurs when the patient has an underlying condition causing weight gain, or more commonly, when a patient consumes more calories daily than he or she expends. Obesity is measured based on a person's weight in relation to height by BMI, but requires a physician or other qualified healthcare provider to diagnose. ICD-10-CM used the nomenclature overweight, obesity, and morbid obesity rather than 1, 2, or 3 BMI scores adopted by the CDC. Generally speaking, overweight corresponds with Class 1 BMI, obese corresponds with Class 2 BMI, and Class 3 BMI corresponds to extreme or severe obesity and is the equivalent of morbid obesity in ICD-10-CM. The National Institute of Health defined morbid obesity as being 100 pounds or more above your ideal weight, or having a BMI of 40 or greater, or having a BMI of 35 or greater and one or more comorbid conditions. When a patient has a BMI between 35 to 39.9 and the provider documents morbid obesity, a clear link needs to be made between morbid obesity and the comorbidity. For documentation validation purposes, the note should also reference morbid obesity in the exam, review of systems, or HPI, and include a treatment plan for weight loss. According to AHA's Coding Clinic, fourth quarter 2018, BMI codes are not intended for routine capture of BMI unless there is provider documentation of an associated diagnosis. There are HCPCS Level 2 codes for reporting compliance with BMI quality measures, and these can be reported in provider offices when a weight diagnosis is not present. Let's look at some examples. Example 1 demonstrates non-specific documentation. The patient's BMI of 42.5 is a BMI that aligns with the definition of morbidly obese, but documentation states obese. The provider should ensure, as in example 2, that the BMI in a diagnosis aligns with the documentation of a weight-related condition. Example 3 demonstrates non-specific documentation as the provider documented that the patient had comorbidities related to morbid obesity, but did not document the specific comorbidity. Therefore, the coder would not be able to assign E6601 morbid severe obesity. There are provisions for a patient with a BMI between 35 to 39.9 to be diagnosed with morbid obesity. However, the comorbidities must be named and linked to diabetes, as in example 4. Malnutrition, insufficient nutrition, or undernutrition due to lack of availability of all foods or lack of the right foods, or due to an inability or unwillingness to eat, which does not meet the metabolic demands of the body. Malnutrition, whether mild, moderate, or severe, do risk adjust. Cachexia is severe weight loss associated with chronic disease that does not correct with nutritional supplementation. In cachexia, the body is in a catabolic state and can't process nutrients and fat. In sarcopenia, there is loss of muscle mass. Clinical indicators for all three, malnutrition, cachexia, and sarcopenia, coincide, thus critical thinking with MDM involving these terms are necessary. When documenting, choose clear and concise language is important. State malnutrition, a diagnosis, rather than malnourished, an adjective describing the patient's appearance. State cachexia, not cachectic, for the same reason. Differentiate between cachexia and sarcopenia. If a patient's weight is causing other health issues such as anemia or falls, document the health issues and link them to the weight diagnosis. Similarly, if cachexia is caused by an underlying disease such as COPD, AIDS, dementia, or malignant neoplasm, document the underlying cause. In example 1, a coder may be able to infer from this documentation that the patient has a nutritional deficit, but without a diagnosis, it can't be abstracted. Only pancreatic cancer, not otherwise specified, can be coded from the note. In example 2, the coder would be able to abstract pancreatic cancer, not otherwise specified, the secondary cancers, and the severe malnutrition. That concludes our review of morbid obesity and protein-calorie malnutrition. These conditions are two of the most frequently underreported conditions when performing a risk adjustment audit. Please feel free to reach out to the IHP coding team at ihpcoding@ihpsocal.org for any other questions. Thank you for taking the time to review the PowerPoint today.